Welcome to the Rocky Mountain MS Center's webinar series. This webinar is discussing West Nile virus and MS DMTs. Our presenters today are Dr. John Corboy and Dr. Daniel Pastula. Dr. Corboy is the director of the Rocky Mountain MS Center at University of Colorado, a multidisciplinary group offering state-of-the-art care and research to MS patients, as well as our medical director here at the Rocky Mountain MS Center. Dr. Daniel Pastula is a board-certified neurologist, CDC-trained medical epidemiologist, veteran of the U.S. Public Health Service, policymaker, scientist, and teacher. This webinar features a lot of information. If you missed something on a slide or want to hear it again, we are recording this webinar and it will be archived on our website at mscenter.org, so you can replay at any time. All live viewers will get the recording automatically sent to them. Today's presentation is for informational purposes only. All decisions regarding treatment and medications should be discussed with your neurologist. We'll reserve time at the end to answer questions from the audience. You can submit your questions at any time by typing them into the Q&A box on your screen. We will answer as many questions as time allows. With that, we'll turn it over to Dr. Corboy.
All right. Good morning, everybody. Thanks very much for getting on, and thanks to Dr. Pastula for joining us this morning. Let's drop right in, and I'm going to share my screen with everybody. So today we're going to be talking about West Nile virus, especially as it relates to the use of the B-cell depleting therapies such as rituximab, ocrelizumab, ofatumumab, and now ublituximab, known as BRIUMVI. So that's a new drug that was approved in December. And the West Nile.
Corboy?
Yes.
Can you put it into presentation mode?
Oh, I'm sorry. Thank you very much. Yes, I should be doing that.
Thank you.
There we go. Much better.
Perfect.
So the West Nile virus is a mosquito-borne virus, and the virus is seen here on the right, and this is a mosquito-borne virus. And Dan, if you could please talk about how this affects mammals and other creatures and how this gets into people.
Yeah. So West Nile virus, so it's an arbovirus, which is short for arthropod-borne virus. So these are viruses that are transmitted primarily by mosquitoes, ticks, and sandflies. And in the case of West Nile, this is primarily transmitted by mosquitoes, specifically the Culex type of mosquitoes. And the Culex ones, you probably are fairly familiar with. Those are those big ones that hang out around dusk and dawn that like to bite you and you feel it, as opposed to some of the other mosquitoes. And these exist in nature kind of in this cycle between birds and mosquitoes. So essentially, the mosquitoes get it from infected birds that then other mosquitoes feed off the birds, and the mosquitoes get infected, and it kind of circles in this. Occasionally, an infected mosquito will go and bite other mammals such as horses or people. And when they bite, then they can kind of transmit in kind of what we call a dead-end host, because the humans and the horses can't give the West Nile back to mosquitoes. So that's what we mean by a dead-end host. So kind of humans and horses are kind of accidental hosts in this case, but it really cycles between birds and mosquitoes. And next slide.
Yeah. And here's the distribution worldwide. And so this is an important disease all over the world.
Yeah, so West Nile was first identified in the West Nile region of Uganda and had gotten imported into the United States in 1999 around New York City for unclear reasons, possibly kind of shipments that had mosquitoes in it or infected birds, or we're not quite sure exactly how. But once it got into New York City, it spread throughout North America in the years since, and is now endemic to most of North America.
And tell us a little bit about the symptoms and how many people get infected and the severe infections as well. Then.
Yeah, of course. So taking all comers across the population, we think, based on serosurvey data, is of people that get bit by a mosquito that's infected with West Nile, about 80% will have no symptoms whatsoever or mild symptoms. Again, this is across the entire population, not any specific population or like immunosuppressed folks. So 80% of people will never know they had it or just have mild illness. So we don't actually know what the underlying rate is. We assume that it's just the number of people that are sick and get tested times 5, or times 4 rather, times 5. And about 20% of people can have like a nasty flu-like illness with fatigue, headaches, joint pains, muscle pains, sometimes rash, sometimes GI symptoms. And sometimes those symptoms can last for weeks, and the fatigue can sometimes last for weeks to months. And about 1% of people, West Nile can get into the nervous system, causing either a meningitis, so that's the infection of the cover of the brain and the spinal cord, which causes really severe headache, sensitivity to bright lights, stiff neck, or it can cause an encephalitis where the virus actually gets into the brain itself, or a spinal cord disease, kind of like looks like polio, so a poliomyelitis, in about 1% of people. Now, that increase, that's across the entire population. People who are over the age of 60, people who are immunosuppressed, people who have organ transplants, people with kidney disease, people who have diabetes have a higher risk of transitioning to neuroinvasive disease. Exactly what that risk is, we don't fully know, but it's higher than 1 in 100.
And we're most interested today in talking about what is referred to as neuroinvasive disease, and that represents the ability of the virus to actually enter the peripheral or central nervous system, and it may be neurotropic, which means it can infect cells of the nervous system, and or be neurovirulent, which is actually cause pathology as related to that infection. And if you could comment just briefly, and I know this is this cartoon here maybe is a little bit too much detail, but how does it actually get to the nervous system? This gets at one of the questions that one of our listeners asked ahead of time.
Yeah, of course. So the mosquito bites you, it injects, again, it doesn't mean to inject, like it's not like designed to inject the virus. It just wants your blood, and as a side effect of wanting your blood, it injects the virus that's in its saliva. So that gets into your skin. Your immune cells in your skin kind of take that virus up, bring it to the lymph nodes. It starts replicating in the lymph nodes and then spreads to the blood. And then once it's in the blood, it kind of disseminates throughout the body. And sometimes it can cross the blood-brain barrier, get into the neurons or the meninges or other supporting cells, and then replicate there.
And is there any known factor that is associated with variations in strains of the virus that allow it to be more neuroinvasive? Is that actually understood or known at this point?
We think that the current West Nile circulating probably has no different neurovirulence than prior strains right now, but we don't really know.
Okay, fair enough. And
it's not like it's evolving that this is more,
right.
Like the percentages of neuroinvasive disease versus not are kind of about similar. So this is not getting more neurovirulent.
And this was, we first saw in Colorado cases in about 2003, started on the East Coast and moved west over several years. And these are the counties that have been most hit. And you can see that they really, Larimer and Weld up north and Boulder, have really had a serious number of cases. Now, there's obviously a fair number of people who live there, but look at Denver, much lower. And so it is variable, and this presumably has to do with a lot of different things, factors with where the mosquitoes may replicate.
Yeah, and so as well as bird migration, right? So you basically, in order to get a lot of West Nile, you need, a lot of birds, a lot of mosquitoes. So where does this occur? Occurs along rivers and irrigation areas. So most of our cases we see in kind of the big irrigation areas in Colorado that are close to the rivers. So you think of up the South Platte and then the Poudre River up north. So that's why you're seeing Larimer, Weld, Boulder, and Adams. It's just kind of along the irrigation areas. And then we also see another focus kind of over in Delta and Montrose, and then out on the Eastern Plains, like along the Arkansas River. And again, it's, that's where kind of like the birds and mosquitoes like to hang out. So it's where you have like standing water, the birds like to go. So really in kind of along irrigation areas. But we do see cases, within the city of Denver. We do see cases, within the city of Fort Collins. So it's not just irrigation areas, but that's kind of where the focus are, within miles of kind of those irrigation areas and farmlands and rivers.
And as noted here, the peak in the last 5 years or so has been primarily August to late September, but we were a little early this year, and presumably this has to do with what you're just describing, and a lot of wet, moist
Yeah.
land, and a lot of flow of water from the mountains after a big snow season.
Yeah, it's not, we don't fully know why West Nile spikes in areas. I don't think it's just as simple as increased rainfall, although that probably contributed to it. It's probably a complex interplay between rainfall, temperature, what the winter was like before, what the birds, in terms of what their migration patterns are, whether the birds are, how immune the birds are at the time for this. And yeah, so typically we think of July through October as our West Nile season here, with it really ramping up August and September. But this year, we're actually seeing a big spike much earlier than normal. So we started seeing our cases in July, is kind of taking off. And we usually see a few cases in July, but they were really taking off in July and have sustained pretty at high levels throughout August.
Yeah, and here's some numbers looking at neuroinvasive cases, hospitalized cases, deaths, and total cases. And I just highlighted here some of the biggest years, especially 2003, and it cycled down, then cycled back up in 7, 13. And then the last 3 years, we can see that there have been a significant number of cases. Now, I just did this number of cases as of last week, a week ago, and already there's a significantly higher number of neuroinvasive cases.
Yeah. So right now in Colorado, so let me preface this with, we only know the cases that come to healthcare that get tested, that are positive. Those tests get reported to the state. So meaning, like, these aren't all the cases out there. These are only the cases that are reported to the state. And then there's also a lag by what's reported to the state. And as of this morning, what's been reported to the state is we have 193 cases, 98 neuroinvasive, with 106 hospitalizations and 13 deaths.
So we can probably expect some more coming over the course of the next month and a half or so.
Yeah, and what ends the season is your first big snowfall or first big freeze, what kills off the mosquitoes.
Right.
So, I don't want to ruin everyone's summer, but, for West Nile, a snowstorm would actually be really good.
And as Dan already mentioned, the greatest risks for neuroinvasive disease are exactly what he just said before. And in terms of diagnosis, most of the time we make the diagnosis with a spinal tap, but you can sometimes make the diagnosis out of blood. And could you comment about this sort of well-known slide for us, which is what we can see as the different techniques that you might be able to use in both blood, even urine, but also out of the spinal fluid?
Yeah. So it turns out that when you get infected, it takes some time for you to get your blood infected by this. And then usually by the time we have neuroinvasive disease, we actually kind of clear the blood pretty quickly. So we don't have a whole lot of viremia, meaning virus in the blood. So it's actually very hard to detect actual virus. So the way we can tell a lot of times is to look for antibodies to the virus, particularly the early antibodies, what we call IgM antibodies. Now, this becomes a little bit more difficult, or a lot more difficult, in people who are on B-cell depleting therapies, where they might not be able to make antibodies as well, novel antibodies as well as otherwise. So oftentimes, we check for serologies on immunocompetent people, but people who have B-cell therapy, if the serologies are negative, but we're still suspicious for West Nile, we'll sometimes go look for the nucleic acid in the virus itself.
And in terms of treatment, there were a number of questions that we received about treatment issues. There's no specific antivirals, and there's no specific monoclonal antibodies or other things directed against this particular virus at this point in time. So treatment is mostly supportive.
Yeah, correct. There's nothing that's been proven. A lot of things have been tried. Nothing has been proven to help West Nile. The only caveat being, again, this has not been proven, but if someone isn't making any antibodies against West Nile, so they haven't seroconverted, and it's really early on, and you can prove it's West Nile, and the IVIG has antibodies against West Nile, it's possible and the person's having trouble clearing their West Nile, so there are a lot of ifs, it's possible that maybe IVIG might be helpful. However, that has not been proven, and we actually, for the most part, very rarely consider doing this, because by the time you have seroconverted, you're making your own antibodies, and by the time it gets into the nervous system, your body's already starting to clear it. So there's no proof that IVIG works. If it works, it's in a very limited, very, very limited setting early on in someone that can't seroconvert and can't clear the virus themselves. But for the vast majority of people, IVIG has been, looked at, doesn't work.
All
So
right.
that's why it's so important to prevent West Nile to begin with.
And the B-cell depleting therapies, as Dan already mentioned, they reduce the antibody response to the virus and also may affect the testing for the antibodies. So this can be a challenge going forward when someone may or may not be infected with this virus. And so that leads to two papers. The paper on top actually is from Dan's group, looking at severe arboviral neuroinvasive disease in patients on rituximab, and then a more recent paper with West Nile virus in association with anti-CD20 monoclonal antibody therapies. And if you could just briefly describe the importance of these papers specifically for perhaps our patients who use these drugs quite a bit.
Yeah, so these two papers came out both this year, and basically, so the first one is all arboviruses, not just West Nile, but other arboviruses such as tick-borne encephalitis, Eastern equine, Jamestown Canyon. Basically, this is suggesting that we're seeing more severe disease in patients on B-cell therapy than we usually see in the normal population. And in the second paper, basically is showing kind of risk in like the Philadelphia area, that there's a much higher risk of neuroinvasive disease among their MS population on B-cell therapy compared with the general population on there. So what this says, both these papers are basically saying, is people who are on B-cell therapies are at higher risk for neuroinvasive arboviral disease than the general population.
All right. And prevention then is the key here, right?
Yes. So unfortunately, there's also no vaccine currently available. So really, it's the vast majority of people that get infected is through mosquito bites. So I would, basically the take-home point here is if you're on a B-cell depleting therapy, you need to be very, very careful about mosquito bites and tick bites, not for West Nile, but other viruses and bacteria that ticks can carry. So the first thing, if you're in an area where mosquitoes are around, wear an EPA registered insect repellent. Some people don't like the smell of DEET. It reminds them of, camping back, when they were young, and everyone kind of knows what that smell is like. But there are a lot of other chemicals that actually have been safe and proven safe and effective. So the EPA has a website where you can kind of go look at all the different options that are shown to be safe and effective. So you have chemicals that have DEET, picaridin, which is based off the pepper plant, IR3535, which is actually an Avon product, which somehow works, but is safe and effective, 2-undecanone, oil of lemon eucalyptus, if you kind of want to go with a purely plant-based therapy. And basically, when you go to the EPA website, you can look and just follow the instructions on there, because the different chemicals have different instructions for that. So that's number one. Number two, wearing or avoiding activities outdoors like dusk and dawn. These Culex mosquitoes really like to be active when the sun is rising and the sun is setting. Basically kind of avoiding those times. And again, the Culex mosquitoes are those big mosquitoes. So like you're going to see them around for that before they, so if you start seeing them kind of flying around, like either wear insect repellent or get inside. 3, wearing long sleeve shirts and pants when feasible. Basically, mosquitoes, it's a lot harder for mosquitoes to bite through clothing than it is direct skin. The other thing, if you're really worried about it, it's not on here. You can actually put permethrin on your clothes. Does not go on your skin, it goes on your clothes. And you can buy it like REI or Jax or, online. You just have to follow the instructions because the liquid is toxic. particularly to pets. But once it dries, it's fine. So you just, when you're applying it, you just have to follow the instructions very, very carefully. And that lasts for a couple of washes, actually, on your clothes. So if you're going to be spending a lot of time outside where there are mosquitoes on, consider treating your clothing with permethrin, or you can buy permethrin treated clothing at like someplace like REI. And then, because we've had so much water around, if you have standing water around your property, if you don't need it, dump it out. Because if it's just standing there, that's a really good mosquito breeding site. And those little wrigglers that you see, those are little baby mosquitoes. So if you see it having standing water around your property, you want to avoid, dump it out, particularly if you see those little wrigglers.
Perfect. So that's the main portion of our presentation today. We did have questions that were offered from individuals hopefully listening today, and I've organized them into a couple different categories. And sort of one category is if you are in fact bitten by a mosquito, what should you do? Is there any way to do anything right away? Should you, to help maybe not get any symptoms? And is there anything you should do about the mosquito to try and maybe figure out if that's infected?
Yeah, so there's no way to tell if a mosquito is infected, like in kind of a normal setting, right? So in specialized tests, they can do it in specialized labs, but essentially we don't, there's no ability to test mosquitoes just around that have bitten people. I will say, even when there's a lot of West Nile around, about we can say that about 1 in 200 mosquitoes are infected. So if you get bit by a mosquito, odds are it's probably not infected. But that means you don't want to get bit multiple times, right? Because there are other mosquitoes out there. So if you get bit by a mosquito, that just says, hey, whatever you're doing in terms of mosquito bite prevention, I'd up that prevention. Because obviously whatever's working isn't working. So I think that just gives you a warning, hey, maybe I could put insect repellent on, or maybe I could wear long sleeve shirts or pants, or maybe I can, stay away during this time. It just basically tells you that, hey, whatever you're doing, you could probably be doing a little bit better for mosquito bite prevention, with odds are that the individual mosquito probably isn't carrying West Nile. Number two, if you are worried about it, basically just monitor for symptoms, right? If you're a couple weeks out of a mosquito bite and you're feeling fine, you're probably fine, because odds are the individual mosquito didn't have it. Additionally, even though that there's a higher risk for neuroinvasive disease, even if you get bit by a mosquito that has West Nile, it doesn't mean you'll get, symptoms from it, right? The vast majority of people don't get symptoms from it. It's probably higher in people who are in B-cell depleting therapy, but it's not zero, right? So, but we don't know what that number is. So even if you get bit by a mosquito and infected, you might not have any symptoms and you might clear the virus, or it might never propagate. Because it's not only whether you get bit by a mosquito or not, it's also the dose, right? So if lots of mosquitoes bite you and they're all have West Nile, that's a much higher dose than if one does it and maybe you feel it and you smack them pretty quickly. It's probably a dose effect of this. So basically the whole point of this is, if she got bit by a mosquito, up your mosquito bite prevention game and try to avoid it again.
Perfect. And there are several questions, and I think I'll take this set of questions, and it has to do with whether or not you would change your behavior with regard to the use of these therapies, the CD20 agents, in this context. And so if you're already on the drug, for example, would you potentially delay your infusion? We know that, for example, with vaccines, if you delay your infusion, you actually get a better antibody response. And maybe you would delay your infusion over the course of the summer. So as your B cells replete, perhaps you'd get a better response to the actual infection. And that is certainly possible. And so we know that you can extend the dosing for a couple of months. From the vast majority of people who've taken a couple of doses of these medicines already, and probably not have any kind of rebound of disease activity with your MS. So although this is by no means proven to be effective to help here, it would not be unreasonable to maybe delay a summer infusion until maybe, end of September or so, and then to go ahead and go with your infusion. The larger question would be, what should we be doing from the point of view of just overall using these medications? We know we've had some issues with increased risk of bad outcomes with COVID, for example, and this is another example of where you can have a more significant disease with a different virus. And so, does this change our view of the world? Yeah, in a big sense, I don't think it changes our global use of the medications, but it is a reminder that we always have to try and determine what are the overall risks of using these medications? How do those risks change over time? And whether or not the potential benefits that are accruing due to this medication are worth those risks. And so in younger patients with very active disease, and younger patients are likely going to do better overall if they're infected with COVID or with West Nile, the risk-benefit ratio probably greatly favors the use of these medications. On the other hand, if you're a relatively older patient, perhaps with progressive MS, and you have some comorbidities, diabetes, high blood pressure, that put you at higher risk of having a bad outcome, and the benefits are not as clearly seen as they are in younger patients with active MS, then maybe that risk-benefit ratio is not so good. So you should be having these discussions with your neurologist essentially every time you see them, and you should always be evaluating this, and that's true for all the medicines we use. And then finally, the larger issue is, should there be development of perhaps more of these so-called immunomodulatory therapies compared to the more immunosuppressive therapies? And maybe that would lower the risk in general for all of these viruses, and especially, as we're talking about today, West Nile. We already have the immunomodulatory therapies available. The older interferons and Copaxone are felt to be immunomodulatory. The problem is that those medications are not as effective in treating the MS. And so what we'd really like to have is a perfectly targeted medication for MS. And in fact, we don't really have that yet because we don't know exactly what the target is that we're aiming at. And so once we get that target better figured out, then we'll be able to have a more specific therapy that perhaps doesn't more broadly suppress the immune system. But for right now, we have what we have, and we just have to continually look at the risks and benefits.
Yeah, and then John, I think you hit the nail on the head here. Like the B-cell therapies work really well for MS that I've seen even just in my career since I've been when I was in residency to now, the B-cell therapies came on board, and just the outcomes are so much better. I think this just shows like this is a potential risk that people should take seriously. We do get some forewarning on these, like meaning that like the state, for instance, the state Colorado Department of Public Health and Environment or state health departments will usually publish when like the first mosquitoes are tested positive and when their first case happens. So basically when if you see that come across the news, that just says, hey, I need to up my mosquito bite prevention game, is when that happens, until we have like the first hard freeze in the area. So we did get a little forewarning on here by a couple of weeks before we started seeing cases, and we started kind of going out in the news and other things. So just pay attention, each season when that happens. Particularly West Nile is the most common mosquito-borne disease here.
And we had a couple of brief questions in the chat. One relates to what actually is IVIG, because that was in one of our slides. Intravenous immunoglobulin. That is, this is a product which is made from hundreds of blood donors, and this is the protein product of the blood, not the red blood cells, white blood cells, or platelets, but the protein portion, which actually carries the antibodies as well as other proteins in the blood. And this is used therapeutically for a number of conditions in neurology and also the rest of medicine. But importantly, there was originally a study trying to take intravenous immunoglobulin from endemic areas, especially from Israel or other places that might have higher titers of these antibodies already directed against the West Nile virus. And that study had difficulty getting off the ground 20 years ago. And I think actually was never completed, Dan, if I can remember. But yeah, the concept is that you might be able to actually give antibodies to people who are infected.
Yeah, the issue is, so first off, yeah, that study had to be stopped early, but didn't show any effect. And the idea is that by the time you get neuroinvasive disease in most people, you've already made some antibodies and you're already clearing it. So basically giving more antibodies isn't going to halt the neuroinvasion in most people. Again, where it might be theoretically helpful is in a very narrow situation where you're not making any antibodies and you can't clear the virus even out of the blood. So where I would consider it is like we're finding actual virus in the blood, we're finding actual virus in the CSF, we're not finding any antibodies and they're really, really sick. That's when I would consider IVIG.
And any particular birds they're affected? I know crows are a big one, but are there other ones as well?
Yeah, so actually, vast majority of birds in North America are susceptible to West Nile. So particularly though corvids, so those are like your crows, blue jays, ravens, and raptors are the most susceptible. Now, some birds are able to, tolerate the virus. That's kind of where they're like the reservoir, where they're just kind of living their life and they've got virus in them, but they're just living their life and learning to tolerate the virus. And that's where the mosquitoes get it from. Whereas like, for instance, crows, for instance, are really susceptible to West Nile. So when they get infected, they can die. And in fact, actually, I've had 2 dead crows in my front yard in the last like 2 months, and I suspect it's probably from West Nile. I will say for all of you, whether you're immunocompetent or not, if you have a dead bird on your property, either call someone to remove it, like your local town, or if you need to remove it yourself, like I'd put a mask on and I'd wear gloves and I would put it right in the trash in a bag and tie up the bag and then wash your hands and be very careful around dead birds. And then make sure your pets aren't playing with dead birds, because dead birds could be infected with something.
And there was a question related to your comment about the freeze. And so when there is a freeze or when there's snow, which presumably is sub-zero or sub-centigrade zero anyway, below 32, does that really just kill all the mosquitoes, or is it possible there are still pockets out there after that?
The Culex mosquitoes, so there are a lot of mosquito versions out there, but if you get a hard freeze, so like meaning if it goes down to like 32 and barely touches 32, that's different when it drops to 20 and you get like a big snow, drops to 20, like sometimes we see in October, like that's what we want is just, the sprinkler busting freezes are usually the mosquito ending freezes.
Exactly. And Kelsey, I don't know if we have any other questions in the chat. There's a question: do the risks change based on age or comorbidities of MS patients on these DMTs? And I think that was alluded to in the slide previously. We know that in medicine in general, if you have multiple risk factors, your risks go up. So the people who, for example, with COVID, using that as an example, who were older, had diabetes, kidney disease, perhaps had gotten chemotherapies for cancer, clearly were at the highest risk of a bad outcome with COVID. And I think the answer is probably similar here, isn't it, Dan?
Yeah, so the short answer is we don't really know like how they interact with your increase in West Nile virus disease, but I assume having more than one risk factor increases your risk. I don't know if it doubles it. I don't know if it one time, if it's synergistic, if it's, I don't know, the opposite of synergistic.
Protagonistic.
What?
Protagonistic?
Protagonist.
Or antagonist. It's
so
actually it's
we don't
antagonistic.
Probably increase it. I'd much rather have one risk factor than multiple risk factors.
Absolutely.
Honestly, but that's really the importance though, is to really prevent those mosquito bites. The additional thing is, if you're looking to also advocate for better West Nile surveillance, you can talk to your local or state government officials. So there are some communities that when there's this thing called a vector index out there where they can certain communities have decided we want to do surveillance on mosquitoes to see how bad the West Nile is. So like, for instance, Fort Collins in Larimer County, they do a lot of mosquito surveillance to see when their mosquitoes are what percentage of the mosquitoes are carrying West Nile, and they track that over time. Other counties and cities decide not to do that. And that's just based on the local city and county and what they decide to put their money in terms of public health surveillance. And so you can kind of go to your local city and county and say like, hey, do you do mosquito surveillance? And sometimes they'll publish when their mosquitoes, have high levels of West Nile. And then some communities have decided to spray for mosquitoes using insecticide when levels get too high. But other communities have decided not to do that. So if you're very interested in this, particularly if you're at higher risk, I'd encourage you all to, go to your, contact your local health department or local elected officials and kind of find out what they're doing for West Nile surveillance and West Nile prevention. And then if you're particularly interested, get involved because that's how things get changed. Basically, when public health works well, everyone kind of doesn't pay attention to it, but public health is so important. And it's really important to kind of support and fund just because we get this warning beforehand when you do good surveillance. So
Exactly. So it's all about prevention and knowledge. So I'd like to thank Dr. Pastula for joining us today. We really appreciate his expertise. I'd like to thank the Rocky Mountain MS Center for putting this on today. And we'll ask all the registrants to please, when you get in the next couple of days, a survey to ask how we did, to please let us know. We listen very closely to all of those. We want to make sure we're presenting information that's useful, helpful, and understandable. So please do that. And also thanks to all the participants who spent part of their morning with us today. And enjoy the Labor Day weekend and have a good time. And if you like hot dogs, eat a lot of hot dogs. But otherwise, everybody have a great weekend, and we'll see you with the next one.
Thank you for your time, doctors. Thank you for all your questions. Just a reminder, the webinar will be archived on mscenter.org and YouTube. And please do sign up for our email list and follow us on Facebook. That is how you find out about future education events. Thanks.